Hello everyone. Today we are going to discuss about primary immunodeficiency disorders. The topic is very much important for all India MCQs. As we know, there are plenty of different types of disease and different types of symptoms are associated with primary immunodeficiency, and these all disease or symptoms are comes in our all India MCQ examination. So we have to know everything in primary immunodeficiency disorders. So today we'll discuss the what is primary immunodeficiency, and then we'll discuss how to suspect primary immunodeficiency, and then we are going to discuss about the brief of immune system and then interpretation of PID from a simple CBC report. So what is PID? PID means primary immunodeficiency. If the immune system is defective since birth, then it is called primary immunodeficiency. If the immune system is defective after birth, then it is called secondary immunodeficiency. There are plenty of causes are present for secondary immunodeficiency. The secondary immunodeficiency, most common cause of secondary immunodeficiency is HIV in adult and also in the children. This is an all India MCQ. There are other causes of secondary immunodeficiency is present. If a child is suffering from nephrotic syndrome and the child is taking steroid for more than 2 weeks and at a dose of more than 2 mg per kg, then the child is suffering from immunodeficiency. It is an MCQs. If the child is suffering from measles and after few days from measles, the child is having secondary immunodeficiency. If the child is going to bone marrow transplantation or stem cell transplantation or taking any anti-cancerous drug for leukemia, then his child is suffering from also secondary immunodeficiency. If the child is taking cyclophosphamide, azathioprine or different types of DMRD, then child may suffer from secondary immunodeficiency. If child is suffering from severe acute malnutrition or severe chronic infection, then the child may suffering from secondary immunodeficiency. So these all are the causes of secondary immunodeficiency, and these all are all India MCQs. So there are different types of primary immunodeficiency is present in children. Most common primary immunodeficiency is selective IgA deficiency. Selective IgA deficiency is the most common primary immunodeficiency in children. Today we will discuss about all the names of primary immunodeficiency and the different types of primary immunodeficiency. In my next video, I will discuss all the diseases and all the types of primary immunodeficiency in a descriptive manner. So first comes to the immune system in a nutshell. Immune system is divided into two types. One is innate immunity and one is adaptive immunity. Mainly causing innate immune system are first is skin, then is gastric epithelial tissue, gastric juices, and the cells and the and the cell and the system which including in the innate immunity system are all MCQs. The cells which causing innate immunity are first is neutrophil, then NK cells, then macrophages, and then complement system. So all are causing innate, all are is a component of innate system. These all are MCQs. All are causing is a system of innate immunity except these four are in the innate immunity immune system. The innate immune system mainly restrict the virus, some intracellular bacteria, and some extracellular bacteria also, and polysaccharide contain bacteria. So the innate immunity is prevent this virus and bacteria. And next is adaptive immunity. The adaptive immunity is divided into two types. One is active and one is passive. So, what is the example of passive adaptive immunity? This is MCQ. If we give ABS or if we give IVIG or if we give any immunoglobulin to any patient, then this is causing passive immunity. That means the immune we giving antigen, we giving antibody against the antigen. So that is called passive immunity. So body do not need to produce anything or do anything to prevent the bacteria to cause infection. So we already provided some immunoglobulin or antibody to the patient. So this is passive adaptive immune system. An adaptive immune system is divided into two types. One is CML. CML means cell mediated immunity. One is humoral mediated immunity. So CMI and HMI. CMI is mainly the component for CMI is T cell, and the component for HMI is B cell. These are our MCQs. So CMI means cell mediated immunity, and this CMI mainly prevent the infection of virus, tuberculosis, parasite, fungus, and some intracellular bacteria. This is very much important. This intracellular bacteria, they prevent from intracellular some bacteria. And the cell mediated immunity is mainly caused by T cell, that is CD4 cell and some activated CD4 cells. So CD48 and CD4, CD8 and CD2 means T8 and T2, T4 cell are mainly causes CMI. These are our MCQs. And HMI is caused by, as I said, B cell. And the bacteria which is the prevent are extracellular bacteria, include some polysaccharide or capsular bacteria. Prevent this. And the component for T cell is the component for humoral immune system is B cell and helper T cell, Th2 cell, and this affected activated T4 cell is Th1 cell. So Th1 is for cell mediated immunity and Th2 is for humoral immunity. These are all India MCQs. Please remember this. Now come to the lymphocyte production. How the lymphocyte is produced? As I said, that lymphocyte is B cell and T cell. This is the two types of lymphocyte are present in our body. So in the fetus, the lymphocyte is produced from yolk sac by multipotent hematopoietic stem cell for the first 5 weeks of gestation. And after that, the liver is taking upper hand from the yolk sac and it is produced multipotent hematopoietic stem cell for 5 to 8 weeks of gestation. After that, bone marrow is produced multipotent hematopoietic stem cells throughout the life and produce lymphocyte in the body. So this multipotent hematopoietic stem cells, this is all I am saying. So this multipotent hematopoietic stem cell may produce B cell, T cell, RBCs, neutrophil, eosinophil, basophil, platelet, everything. So this multipotent hematopoietic stem cell first by the interleukin 3 and interleukin 7 is divided into two parts. If the interleukin 7 is positive, then it will produce common lymphoid progenitor. If the interleukin 3 is positive, then it may produce common myeloid progenitor. From the common myeloid progenitor, they divide it into RBCs, basophils, monocyte, eosinophils, platelet, neutrophil, everything. And from the common progenitor lymphoid, they divided into two parts by the CD7 positivity. If the CD7 is positive and if the CD7 is negative, then if the CD7 is negative, then from the common lymphoid progenitor, it will produce B cell. If the CD7 is positive, then common lymphoid progenitor will produce T cell. The marker, CD marker for B cell and CD marker for T cells is common all in MCQ. The CD marker for T cell is CD3 and CD marker for B cell is CD19. Now this progenitor B cell now in the bone marrow undergoes some process to produce mature B cell. This progenitor B cell first produce pre-B cell by some enzymes and some interleukins. After that, this pre-B cell produce immature B cell by tyrosine kinase enzyme. By the gene produced tyrosine kinase enzyme is BTK gene. This immature B cell then divided into mature B cell by some interleukins, and this mature B cell will produce antibody after getting involved with some antigen. This pre-B cell and progenitor B cell, they having intracellular antibody like IgM, but not in the surface. This is all in MCQs. They having intracellular IgM, but not in the surface. This immature B cell having intracellular IgM and IgD, but not in the surface. This mature B cell having surface IgM and IgD. This is all in MCQs. So if there is positive and if there is defect in the BTK gene, and this will produce some disease, and the disease name is X-linked acamaglobulinemia. Because this BTK gene will not produce tyrosine kinase, and the tyrosine kinase by the deficiency of tyrosine kinase enzyme, the PB cell will not produce immature B cell, and after that there is no production of antibody. So there is a deficiency of antibody and causing gamma globulinemia. That is a causing Bruton gamma globulinemia, and this is X-linked recessive disorder, and this is only seen in male child. Now the T cell from the bone marrow, they enter to thymus, and the thymus they are going to positive and negative selection. What do you mean by positive and negative selection? These all are all India MCQs, positive and negative selections. And by the positive and negative selection, they will produce mature T cell. And this mature T cell enter to secondary lymph tissue. What are the secondary lymph tissue? These all are MCQs. Secondary lymph tissues are mainly, one is lymph node, one is spleen, one is Peyer's patches, and tonsil. These are all secondary lymphoid organs. And the primary lymphoid tissues are thymus and bone marrow. These are primary lymphoid tissues. These all are MCQs for all India. So these are primary lymphoid tissue, and these are secondary lymphoid tissues. So what do you mean by positive and negative selection? And what the selection present in for B cell? So what do you mean by positive selection? In our FD cells, there is presence of MCH. MCH1 is present in all the bodies, all the cells in the bodies, and MCH2 only present in the antigen presenting cells and some T cell. This, if any cell is MCH1 positive and the T cell will recognize this is their own body cells and will not hamper these cells. It is called positive selection. That means we will not causing any hamper to this MCH1 positive cell. It is called positive selection. And if any cell, any T cell is having defective positive selection, and after that the cell is come in the body, and they will hamper the MCH1 positive own body cell and produce auto antibody, and body will in the follicular cell of the lymph node, they see that the defective T cell are present and they will hamper all the body organs, and they causing apoptosis by some interleukins, and they kill the T cell. That is called negative selection. That means the cells which causing autoantibody in the body, then this cell will be destroyed by apoptosis by some interleukin processes. This is called negative selection. And positive selection is there, the body will show the MCH1 to all the T cells, and they tell the body to see that this is the own body's own cell, and you will do not do any hamper this cell. This is a positive selection. So negative selection is present in T cell and also for B cell, but there is no negative selection. Positive selection is seen in B cell. So there is no positive selection for B cell, but T cell is having both positive and negative selection. This is all your all in MCQs. So if their thymus is absent or there is absence of thymus or the thymus is not produced in some diseases, then the T cell having some defect to going to this positive and negative selection and the maturation process of the T cell, and the T cell count will be decreased, and this is the disease in which thymus is absent is Digeorge syndrome. In Digeorge syndrome, there is absence of thymus. Third and fourth branchial arch is not produced, and this is called Digeorge syndrome. This is always an MC. Digeorge syndrome. Now, how this mature B cell produce numerous antibodies? We have to know, because some primary immunodeficiency occur by this process. In this process, the antigen presenting cell attached to T cell, helper T cell, that means TH helper cells, and they show the MCH2, and by this they produce interleukin 2, and this interleukin 2 stimulate the B cell, the antigen presents in the antigen presenting cell, and this antigen presenting cell, the antigen from the virus first attached to TH helper cell, and they by the MCH2, and then produce the interleukin 2, and we stimulate the production of B cell. This B cell will also attach with the antigen presenting cell, and then B cell get some numerous changes in the intracellular, and they produce some numerous enzymes in the body, and from the B cell they produce antibody plasma cells, and the plasma cell causing production of antibody. These antibodies mainly first they produce IgM, after that they produce IgG. So from IgM first then produce IgG. This is called class switching. So how does class switching is occurred? That means how IgM now produce IgG, or the cell produce Ig, how does plasma cell produce IgG now? So there are different types of gene present in B cell. As we know, the antibody having the light chain and the heavy chain. The light chain, the first portion of the light chain and the first portion of the heavy chain produces the variable parts, and all are, and the rest are constant part. This part is mainly produced and mainly attached with the antigen, and they causing the bacteria to kill. So how this part is formed? The VDJ genes, and there are numerous different types of genes present. By the permutation combination of these three genes, they produces numerous types of different types of antibody. If there is any disease causing this permutation combination failure, then they do not produce any Ig gene, and this is happened in CD40 ligand defect, and this is called hyper IgM syndrome. That means the B cell, after the B cell get after interleukin 2 stimulate the B cell, then the B cell, when attached with the antigen presenting cell, the antigen presenting cell also attached with CD40 ligands of the B cell. This CD40 ligands stimulate the B cell to produce some enzymes and make the VDJ genes make some permutation combination and produce some antibody like IgM, IgG, IgD, IgE, or different types of Ig immunoglobulin. So this class switching is not happened if the ligand is not present. So this is, if the ligand is defective, then there is no class of chip. That means the IgM will produce, but the IgG will not produce from the mature B cell. And this is seen in hyper IgM syndrome. This is called hyper IgM syndrome. I will discuss everything in my next videos. Now, how do we suspect if a child having PID or not? So the suspicion is comes if more than 2 of the following 10 point is present in any child. More than or equal to 2 point is present in any child from the following 10 points, then we suspect the child may suffering from PID. And this is the 10 warning sign of Jeffrey Model Foundation, 10 warning sign to suspect the PID. So what are the 10 sign? The first sign is 4 or more than 4 new ear infection in within 1 year. More than equal to 2 serious sinus infection within 1 year. 2 or more pneumonia in 1 year. 2 months of antibiotic with little effect. Failure of an infant to gain weight or grow normally. Recurrent or deep skin or organ abscesses. 2 or more deep-seated infection including septicemia, meningitis or cellulitis. Need intravenous antibiotic for the every time to clear the infection. Persisting thrush in mouth or fungal infection of the skin. Or lastly, if there is any family history of PID. If any 2 of the following 10 points is positive, then we suspect the child may be suffering from PID. Now, what are the different types of PID? So, we divided PID into 5 types according to the different defect in different system. First, as I said, the adaptive immunity is divided into 2 parts, active and passive. The active part is also divided into 2 types. One is cell-mediated immunity, one is humoral immunity. The cell-mediated immunity is mainly done by CD8 and CD4 active T cell, and humoral immunity is mainly caused by B cell. The T cell mainly prevent the infection from fungus, virus or some tuberculosis, parasites and some intracellular organism. That means the child may suffering from day-to-day normal viruses or some serious fungal infection, bacterial infection or some parasite infection if they are having cell-mediated immunity defect. If the child is suffering from B cell defect, the child is suffering from some extracellular or capsular or polysaccharide bacteria. That means the bacteria is mainly causing the ear and respiratory tract infection. The child is suffering from this. The child will protect from viruses to some extent, bacteria and also the funguses. So B cell defect is much less lethal than T cell defect. So what are the different types of B cell defect? First is Bruton's gamma globulinemia. As I said, there is BTK gene deficient. It is an X-linked recessive disorder and it is caused by BTK gene defect and the decreased production of tyrosine kinase. The immature, the pre-B cell will not produce mature B cell and there is no antibody present in the body. Next is CVID, that means common variable immune deficiency. That means the B cell is now mature, but the B cell will not produce antibodies. How? I will discuss in my next videos. So CVID is called common variable immunodeficiency. Selective IgA deficiency. That means the IgA is deficient in this patient. And this is the most common overall PID in any child. Then after that, IgG subclass deficiency. There are four types of IgG in the body: IgG1, IgG2, IgG3, and IgG4. The IgG1 is mainly causing prevent from infection from diphtheria, tetanus, or some intercellular infection bacteria. The IgG2 mainly prevent from polysaccharide bacteria, and IgG3 mainly prevent from fungus, and IgG4 sorry IgG3 mainly prevent from virus, and IgG3 mainly prevent from parasite. So this is from parasite, this is from virus, this is from polysaccharide, and this is from intercellular infections, bacteria. And lastly is IgM's hyper IgM syndrome. As I said, if there is no class switching is present, and then there is production of more amount of IgM, but IgG is not produced because of CD40 ligand defect. So this is called hyper IgM syndrome. Now come to the T cell defect. First is WAS. What do you mean by WAS? This is called Eldridge syndrome. The child is suffering from atopic dermatitis, thrombocytopenia, and recurrent infections. The protein causing Wiskott-Eldridge syndrome is WAS protein, and it is an X-linked recessive disorder. This is also X-linked recessive disorder. That means it is mainly seen in male, and this is also seen mainly in male. Then there is Digeorge syndrome. As I say, there is a aplasia of one or deficiency of production of thymus. There is no T cell is produced, and no T cell is matured by this in this disease, and there is a post facial deformity. There is a coarctation of aorta in mostly present in heart. There is hypocalcemia due to no parathyroid present because third and fourth pharyngeal arch defect. The gene causing Digeorge syndrome is mainly 22q11 in the chromosome number 5. Then SCID, that means severe combined immunodeficiency. Then ataxia telangiectasia. Child is suffering from ataxia in infancy. Then there is a multiple telangiectasia in the eye, and child having multiple episode of recurrent infection. Chronic mucocutaneous candidiasis. There is a presence of recurrent candidiasis, and also there is some skin infection is present. Next, cartilage hair hyperplasia. The hair is white in nature, and also there is dwarfism present in the children. That means fine white hair with dwarfism with recurrent infection, we will suspect it may be a case of cartilage hair hyperplasia. Now, granulocyte defect. The first is LAD, that means leukocyte adhesive disorder. The leukocyte, that means neutrophil, is present in the blood, but it cannot go chemostasis to the inflamed site. After that, this is CGD, that means chronic granulomatous disease. Complement defect, there are different types of complement defect is present. Complement 1, complement 2, complement 3, and different types and so on. And the child is mainly suffering from polysaccharide bacteria, and also the lastly is cytolytic defect. The child is suffering from HLA syndrome, Gracile syndrome, the child having sparse hair and no eyebrow, white hair, and hepatosplenomegaly with recurrent infection. The child may suffering from Chidiac-Higaisi syndrome. That means child is suffering from albinism and recurrent infections. So these are the different types of PID. Now, interpretation of PID from simple CBC. As I said, there are different types of PID present, and if in CBC report, if a child is suffering from infection and in CBC you found that hemoglobin is low, normal, total count is much more high, That means more than 1 lakh. 1 lakh. Neutrophil is high, lymphocyte is high, and platelet count is low or platelet count is normal. Then think about the child is suffering from multiple infections, then think about LAD. That means leukocyte adhesive disorder. If the child is having normal hemoglobin, the total counts is normal and child is suffering from eczema or atopic dermatitis and there is multiple purpura or bleeding spot present and the platelet count is low, then the child may suffering from Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome. Now, if the hemoglobin is normal, the total count is low, the neutrophil count is low, lymphocyte count is low, and platelet count is normal, then the child may suffer from some defect in the T cell productions. That means the child may suffering from SCID. That means KID, severe combined immunodeficiency, or the child may suffering from other diseases like diagnose syndrome or Wiskott-Aldrich syndrome. If the child suffering from normal hemoglobin but total count is normal but the neutrophil count is low and lymphocyte count is normal and the platelet count is normal, then the child may suffering from febrile neutropenia. Now, if a child is suffering from normal hemoglobin, the lymphocyte total count is low to normal, the neutrophil count is normal, but the lymphocyte count is low, and platelet count is normal, then the child may suffering from recurrent infection. If the child is suffering from recurrent infection and there is no tonsil is present, then think about X-linked agammaglobulinemia. By this, then CBC, we can differentiate these types of different diseases in a nutshell. So today, this is all for today, and we'll discuss all the diseases in descriptive manner in my next videos. Thank you.